Maintenance therapy is emerging as a very attractive paradigm in the treatment of patients with advanced stage ovarian cancer. Part of this really parallels our understanding of the molecular drivers of these malignancies, specifically with the data following PAOLA-1 in the BRCA mutation population, with the dramatic improvement in progression-free survival, with incorporation of olaparib in the BRCA mutated population, a hazard ratio of 0.3. We have now brought olaparib into the frontline maintenance setting for patients who have a germline or a somatic BRCA mutation. And that is now part of clinical practice and really ties to the importance of germline and somatic BRCA testing in these patient populations. In parallel, we've had several studies recently that have also explored maintenance frontline PARP inhibitor, niraparib specifically, or veliparib, in patients extending beyond the BRCA population. So rather than just focusing on the BRCA mutated patient population, we're asking about the relevance of maintenance PARP inhibition in patients who have a complete or partial response to frontline platinum combination therapy, in patients who are BRCA wild type, homologous recombination deficient, or homologous recombination proficient. And the data from these trials was published in the New England Journal of Medicine, showing a preserved benefit across platforms, across these trials, for maintenance PARP inhibitor in the intention to treat all-comer population. And the third study that followed in the same breath was the PAOLA-1 trial, which also looked at a maintenance olaparib plus bevacizumab combination regimen. And the NCCN guidelines that were recently released and updated in 2020 speak to this incorporation of a maintenance strategy, stratifying patients as we make our clinical determination based on their germline and somatic BRCA status, in an effort to help us think about how we're going to approach maintenance in these patients, what our maintenance therapy options are currently. And again, those include the maintenance PARP inhibitor olaparib. Our FDA approval at this time is in the germline and somatic BRCA mutated patient. That may potentially expand to the non-BRCA mutated population, although we don't know that yet. Maintenance bevacizumab, which again is already approved in the frontline setting, and potentially the opportunity for a combination of maintenance olaparib plus bevacizumab based on PAOLA-1. Again, that approval has not yet been determined, but could potentially be an opportunity for our patients in the future. In the clinical trials that were performed to try to determine the benefit of a maintenance strategy, the goal is to expand maintenance, again, beyond patients who have a BRCA1 or 2 germline or somatic alteration. The PAOLA-1 study was an investigator-initiated trial, and it looked at the combination of olaparib plus bevacizumab versus bevacizumab plus placebo in frontline patients who had primary or interval cytoreductive surgery, and again had a complete or partial response to primary therapy. And the randomization was performed, and the intent was to see whether or not there would be synergistic benefit in combining bevacizumab with the PARP inhibitor olaparib versus using olaparib alone. And what we saw in the intention to treat population in all comers, there was a 6-month improvement in progression-free survival with the combination over single agent olaparib, from 60 months to approximately 22-month median progression-free survival. And what was very exciting was in the BRCA mutated patient population, the hazard ratio was 0.3 once again, with what we would consider an active placebo arm, because the patients in this study that were randomized to either bevacizumab, which based on GOG 218 and ICON 7 we know is an effective strategy, versus bevacizumab plus olaparib, and the hazard ratio in the BRCA mutated population remained at 0.3. So 70% reduction in the risk of disease progression in the combination arm. So very exciting data, significant PFS numbers. There is some dialogue about what the relevance would have been of an olaparib monotherapy arm on the PAOLA-1 trial, meaning olaparib plus bevacizumab placebo plus bevacizumab, and adding a third arm that would have been placebo plus olaparib, so that we can really define the relative contribution of the addition of bevacizumab to olaparib in the BRCA mutated and the HRD population. Now, that is data that we do not have. Nonetheless, the data that we did abstract from the trial results was really incredibly exciting, again, with an intent to potentially open the maintenance landscape to patients beyond the BRCA1 or 2 mutated population.